and of course Amanda, our youngest person in the room, and I were texting all morning, right? But it's an important element, and it was wonderful to meet you over the phone, but this is different. And what I have seen in our communities where we have some super specialists that sort of take ownership of and sort of a parental mentoring role of a community, the relationships that occur are a very valuable asset to build. And then the question is, how do we use technology to enhance that? Now we have the opposite kind of story told by the Gunderson physician you brought out. Bob Trine is with us today. He's a senior strategist for Gunderson in Wisconsin, where he basically said, look, if I can't get my patients in control, I go out to their house and I find a way, even if they can't pay me, if they just give me a beer. It's so the Wisconsin model and the LA model are obviously completely opposite, but
there were a couple of challenges though. I mean, it is rural and remote communities, so we did use e-consults. We also did a fair amount of outreach specialists going out to work with general practitioners around the region. But we also found that 7% of the population looked at chiropractic as their primary care provider. So we had a very active outreach to the chiropractic community, and we did training, and we just made sure that they had access as well, and they were not employed. The rest of our doctors were employed. We did actually start hiring them some, but for the most part, they're independent doctors.
So I have to say that one of the disruptive innovations that they're using in our San Diego University best practices, and I think Ron Scott would be able to talk about, is the use of the poly pill, which is really in America the poly pack. The Kaiser developed model of aspirin, lisinopril, and lipid-lowering agent, or in the case of a hypertensive, adding the thiazide, so the tall or the all protocol. And I think that is just, if we just bring it back to what are we really about here, a very disruptive innovation is to say, and we were just talking about this at Stanford yesterday, on the triangle here, on the back, the two bottom parts here are use of medication protocols and use of other team members. This example is pharmacists on the care team. And just being very, very intensive about developing what you said, which are, gosh, I may be merging meetings here, but the idea of order sets and simplifying so that at the VA or at Kaiser or other large systems, and hopefully we can get it out into the community pharmacies. Ralph's Pharmacies has been very helpful in partnering with some of our university best practices folks to spread innovative ideas. Can you talk a little bit about how you are extensively benefiting from the use of the ALL and the TALL protocol at Kaiser, and what you're doing with the community clinics to spread that?
Yeah, so a lot of patients, we think about a lot of times these silos of hypertension and dyslipidemia and using aspirin, and then there's diabetes, and just kind of finding the common ground and looking at it from a very simplified, patient-centric perspective. That a lot of these things you can, use once a day medicine. It all can be taken together, So right now, I mean, we worked on poly pill or poly packs, but they didn't quite work out. So we're just giving people pill boxes a lot of times in Kaiser, and saying take your statin, aspirin, and blood pressure pill. I mean, I'm going to give a talk next week. I'm calling it prevention CAB, so CAB for cholesterol, and then A, aspirin, and B for blood pressure, or Million Hearts campaign calls it the ABCs. just bundle them all together, take them once a day and make it one little easy task as you market it to the patient for the patients that qualify for all three by guidelines, and then trying to implement that bundle for the patients that qualify for all three and make it very, very easy.
To me, the question is, there's lots of medications or combination of medications that have been shown to be efficacious. Well, what did you guys do at Kaiser then to, as you said, implement, right? How did you get the doctor, patient, nurse, pharmacy combination, or did you just say, in the formulary, this is all you can order?
Right, right. It's a combination of factors, and you alluded to a lot of them in your talk. I mean, we have this guideline process that it's kind of like the specialist primary care partnership. We have these committees of people working on guidelines and protocols, and we say, okay, this is the target population that we're going to do this on, and it's thoroughly vetted. So a lot of times it's consistent with widely accepted guidelines, and primary care providers, like you said, I mean, even though some are not real enthusiastic, they end up going along with a lot of these protocols because it's just easier, and we have it set up, and we program the electronic health record to facilitate it, and we train all the pharmacists and nurses that are rooming the patients or talking to the patients in the pharmacies. They're all on board. We organize our whole system around these protocols that we write. We even have now, we can directly online through patient portals, they can see, oh, I qualify for all these meds. I'm going to go ask my doctor for them. So then the doctor, all he has to say is yes, and the patient starts the three. If they're educated and willing to go on their portal, which not all patients are. If they struggle with computer literacy and things, then you need somebody to outreach to them. But we just organize all these different aspects of our system around delivering these high-yield, cost-saving interventions. And that's the other part, is if it's cost-saving to the system and reduction in hospitalizations, reduction in revascularizations, and then it's a win-win, really. It's patients are healthier and the health system makes money.
Kelly, yes.
The other thing that we do a lot at Kaiser that we've just been doing in about the last 12 to 15 years is some unblinded performance reporting, where we send an email out to all the family med doctors at the medical center. It's got each of their rates of prescribing at least moderate intensity statins for their patients with ASCVD and the low or the moderate for their diabetics, depending on their A-risk. And an email, I mean, Ron does this, he just sends it out. A lot of our physician leads do, and then it really changes behavior. But you've got to do all the selling and proving first before you can go to that point.
So I have a sort of controversial question, but I'm actually interested in knowing the answer. Do you think over the last 10 to 20 years that one of the interventions at Kaiser is actually the sort of self-selective process or the active selection of particular kinds of providers who are, nature rather than nurture, but by nature gravitate to this sort of approach? I ask that because I wonder to what extent it's important to have people on the team who believe in something versus what I think we've had to do in a very quick period where we have no control because of civil service over who joins us, right?
I think it's about getting them excited. So in San Diego, what we did was we had Jim Duddle, who was with us at Stanford yesterday. He's their national, was he the creator of the ALLTAL? He was certainly part of the team. Yeah. He's in his 70s and he's very passionate about teaching this work. What he's done in San Diego, because that's where his home is he's partnered with the UCSD cardiologist, and they have created something called the Heart Attack and Stroke Free Zone. And so in the university best practices every month, that was the first one I started. I recruited both of them. And then they got the other physicians at the major systems. I mean, there are fewer systems there than there are here. LA is so much more complicated. But they made an agreement that everybody, all the systems, Scripps, Sharp, UCSD, Kaiser would intensify asking the question, everybody on the team, does this person belong on the aspirin, lisinopril, lipid-lowering agent bundle, and there's, or tall, the adding the thiazide, and to make an effort to make sure that everybody who needs those medications according to, are you diagnosed with heart disease, are you diagnosed with hypertension, are you diagnosed with diabetes and over the age of 50, then put them on the protocol. And what they did was they got a grant to, from CMMI to see if they could do it across the community where they, each of them could have the coach of their choice to implement, to do that patient outreach. And Jim Duddle was just telling me yesterday that across the 3,000 patients that were enrolled in this, they've had like shockingly low level of events. I can't say the number, but it's about a quarter or a fifth of what the Archimedes model or our OSHPA data that we went over here last month would have anticipated. So by using what we know, and this is very inexpensive approach, they are working the formula across the whole community to get to zero. So
It's only 3,000 patients, so it's a study.
it is, the people who are in there are the study, but across the whole community, since we started there in 2011, and our very first activity in actually January of 2011 was to have a conference that was co-led by Bob Kaplan, who had been, he's at Stanford now, he'd been at NIH, ARC, UCSD, and Jim Duddle and some of the other brainiacs came together to talk about the value of this polypharmacy. You know, can we use this bundled approach of these very, you know, inexpensive generics to change the curve? And it's really quite a dramatic improvement, and it'll be published in a few months in the American Journal of Managed Care. So I think it's just a worthwhile to consider how can we do that in this more, I'd have to say, complicated environment of LA, where how can we get, say, your champions at Kaiser to help maybe create some relationships across your physician community,
Gotta work
get them
on
excited
Tony.
about it.
This is Tony, DP, right? Just so everybody knows, DHS is only responsible for 5% of the residents of LA County,
5%.
right? Kaiser's gotta have way more than we have, actually. Probably 30%, 25%.
Yeah, probably.
But Tony is responsible
Tony
for
Quote had to
everybody.
leave early, right?
Yeah, no, I
right,
know.
right, right.
But
Yeah.
DPH is, we'll play. We will, I commit to this, if everybody else does, we can do it.
And I think your question of how willing physicians to go along, I think they're salaried physicians, which yours are. I think the way they, and also if there's an ability to create some tactics toward panel accountability, which we go back and forth a little bit in Kaiser, this mentality of I'm a urgent care doc, you know, with my panel, and I can only handle 10 minutes of care for them, and then they're on their own again, versus having this accountability for their health, and various metrics on their health for my panel, you know, and having enough primary care providers to create this accountability. And as salaried physician, I think those are building blocks. And in San Diego, fortunately, there's high penetration of managed care, and they have driven down throughout San Diego County, the whole county, all the patients, regardless of what health system they're in. The heart attack and stroke rates have gone down, seems like related to this initiative, and that's what they're going to publish. So it is exciting impact they're having, not just on the 3,000 patients, but
Yeah,
on,
it's
you know,
impressive.
millions in the whole county potentially. But I think those two elements would really help, having salaried physicians and then this ownership of somebody for their panel and the help of their panel. So.
question about,
Could you say your name?
oh yeah, I'm Melina. I'm from the Department of Public Health, but I cannot speak for Dr. Quo. But I have a question about, you'd mentioned the sort of highly complex patients, that there was a proposal to apply an intervention, and it turned out that, fewer than 10% of them, I think, had been seen in the last year. And I was really thinking about, even within DHS, which is pretty big, even though it's small for a small proportion, what proportion of patients are sort of intermittently showing up or fall out of care and then pop back in? And I mean, I know it's not central, we're talking about a protocol for treatment, but.
That's really central. I mean, we haven't talked about it here, but certainly what happens in other countries, for instance, is the pharmacist is the frontline team.
Yes.
So when I think of my mother who died suddenly of a stroke from uncontrolled hypertension when I was 15, she was in and out of the pharmacy all the time to get things for her ailing father, her husband, her 4 teenagers. But she would not, she's one of those people that didn't think she ever needed to go to the doctor and never went to the doctor. But if, I mean rarely, but if we would use what, like you said, let's meet patients where they are. And where they are, those diabetic patients you were mentioning with the hemoglobin A1C over 10, a lot of those can be very quickly gotten into control by Ralph's pharmacies, Safeway pharmacies, USC pharmacy students. There's a lot going on in that space, and it's a little strange, frankly, that we have the knowledge of the power of these underutilized practitioners, and yet, and I've heard Diana Dooley, the Secretary of Health and Human Services for California, say how important this is, and yet the resistance has been amazing. And in San Diego, actually, we had a wonderful experience where Rebecca Cupp, Vice President for Ralph's, plus Jan Hirsch, who you may know from UCSD, and a few other of the pharmacists, gave all these presentations for our 2-hour session about how this works. And a former Navy SEAL, physician to the Navy SEALs, Dr. Scott Flynn, who's not with us today, he's a Blue Shield medical director, he told me that he thought it was absolute hogwash, but that he found the comparative effectiveness trials so compelling that he went and took it back to his medical group at the time, and he tried it, and he was blown away. That frankly, the physicians loved it because it lowered their workload, and their patients got in better control. So now, that's one of the models that across San Diego, all the medical groups are using.
I was thinking another potentially, disruptive model of some sort of, like we have this huge geography, you showed the slide, I mean, mobile access, or, dealing with the issues that the patient, the challenges and the barriers to patients' compliance, in addition to their, sort of fears or emotional issues.
We don't know the answer to your question, that first question, by the way. We take auto assignments as well as our own panel patients, and so it's sort of predictable that if you're auto assigned a patient who's not even part of your system, that they might choose not to come to us. It's probably pretty dichotomous, right? We have a bunch of people who never see us, and then we have a bunch of people who will always see us because they've always seen us. And then there's some, group that's testing us.
I just want to interrupt for just a moment, and we'll continue with that, to say, physicians, nurses, quality improvement folks, if you would fill out your CME forms, we will be able to keep providing it. But if people don't take advantage of the CME, it is an unbelievable amount of work to bring it to bear, and LA Care isn't going to continue to provide it for us if nobody takes advantage of it. So yes, Lord, you should definitely fill that out. I'm sorry I interrupted that important dialogue. So when you were saying mobile, are you talking mobile vans, mobile phones? I wasn't.
Maybe mobile pharmacists. Or, well, I don't know. Any sort of, but sort of acknowledging some of the barriers, and I mean, we're coming up with navigation models and things like that, but I think that the question of where is the patient, I'm really interested in.
So Steve is taking a lot, I know that he's taking a lot of wonderful labor out into the community, but he has a terrible a respiratory issue right now, so he might not be able to project if somebody.
Well, I was going to say that we do have a barbershop-based intervention with Ron Victor as the lead PI, which is really taking it to where the high-risk patients are, and that the results are phenomenal. The first phase is actually the pharmacist taking care of the hypertension in the barbershop. The second phase is handing it off to HB pharmacy. So I think, as Hal said, there are all sorts of opportunities to find those hot spots for the high-risk populations. Hattie, to your point, I was going to say, nobody believes in the value of integrated pharmacy until they experience it, no matter what data they look at. I think it's very hard for people who have never worked with a pharmacist in a clinical setting to imagine that the pharmacist, and this is, Lauren, this is not a negative comment at all, okay? So sit down, please. Their perception of my pharmacist in that chain retail drugstore is actually going to do clinical work with me side by side. They don't get that. Because what they get is they get calls at the end of the day about prescription problems. They don't see them as clinical partners necessarily. Now that's changing. But no matter how much data you show any health system that hasn't experienced it, until you get the pharmacist and even in a pilot, they don't believe it. So I have to say thank you to Hal, because we do have a pilot. We're starting our replication of our CMI grant. LA County across the street.
A pilot, we're doing it.
Oh, we're doing it. Sorry, we're doing it. You're right. We're doing it.
There's some that you qualify to get money for it from outside, but we're doing with and without you stuff that's embedded. I do want to make the point that it sounds like this medication combination is terrific, and I need to look into it and tell our endocrinologists and blood pressure people to do that. But the part the disruption, just to make the definitions clear, is the part that results in it actually being utilized, as opposed to just the idea. And the complexity of it, just to give you a sense, is literally yesterday afternoon, I composed an email or memo that's going to go out to all of our providers, explaining to them the great value in having our patients come to our clinics to have their prescription filled, and not take it to whatever clinic, including Ralph's, out there. And the reason why is the way that we can link the combination of medications to make it truly disruptive to get to people is if we can capture the data. And it's just so hard for us, or let me put it the other way, it's so much easier for us when the patients come to our pharmacies, which allows us to capture that data, that allows our clinical pharmacists to engage with them. It's a lot cheaper for us. It allows us then to refill their medications a lot easier. It allows us to do our central pharmacy fill-in mailings a lot easier. And that's a challenge in itself, because so many of our providers don't think there's value to using our pharmacy. And in fact, commercial pharmacies are very good about marking their services to the patient. So we've got a real-life challenge of how do we do it. It's not to say that the outside pharmacies aren't doing the job they're supposed to do, but we have no way of coordinating, right? It doesn't even appear in our electronic health record. We can't do medication reconciliation.
That is
That's the
exactly the
challenge,
barrier. That's the barrier to adding the pharmacist to the care team. But in terms of the poly pill or the poly pack, or using tall or all, Ron or Kelly, you don't really do that through the pharmacist, right? I mean, it's an idea that you can pair those two ideas together But it's
Hal's-
really your
Hal's right.
primary
Having an
care.
integrated pharmacy is critical, actually. Our
Could you say
patients-
that louder? I'm sorry.
Hal's right, that having an integrated pharmacy system that you can see the data is critical. Although, because we have all these adherence outreach programs and all kinds of things that really, we have a bunch of patients that go fill their meds at the VA because they have dual coverage or whatever. And we're like flying blind, we feel like, with
Because if
them.
they
We
don't take it,
We
you
don't
don't get
know
the
whether or not
benefit.
they're taking their pills. It's hard for us to tell. Yeah.
Well, this has been a very rich discussion. We're 5 minutes over. If nobody has any burning questions or comments for today, I would just like to flag for you that next month, and Carla, if you could help me with the exact date, March 20th. March 20th, instead of meeting here, we're going to have a special combined meeting with the Health Services Advisory Group and the Pacific Business Group on Health, California Quality Collaborative on care transitions across settings at Good Samaritan Hospital. And that's going to start with a meal from 10:30 to 11:30, then programming from 11:30 to 3. Steve Chen will be on that agenda talking about medication safety. We'd love to have you there, but we just don't, one of the complexities of working in LA is finding the right meeting place and finding the large enough meeting place, because that's gonna have about 150 people there. So, I don't frankly know where Good Samaritan Hospital is, but I will find my way there by March 20th, and hope to see a lot of your faces there. Carla will be sending out from the Right Care Constant Contacts an invitation to you this coming week. And thank you so much. Awesome job.